Hello and welcome everybody to the Nursing and Midwifery Sustainability Network. My name's Angela Hayes, I'm the Nurse Fellow and Project Lead. We meet monthly and we have really interesting speakers, of which we have a really interesting one today, David Renard. So David is a nurse in emergency and critical care and tropical medicine. He has a master's in global health and started working for Médecins Sans Frontières, Doctors Without Borders in 2012, primarily in trauma care, but settings across the Middle East. David is now an advisor for sustainable medical practices as part of the organisation and of the Rethinking of Single-Use Medicine Medical Items project, where he works to integrate an environmental perspective into Médecins Sans Frontières medical practices. So today David is going to tell us about his sustainability journey. So if that's all right with you, David, I'll turn my camera off and hand over to you.
Yes, that's great. Thanks for the introduction. Thanks for the invitation. I'm really glad to present this Center of Sustainable Healthcare platform. That's an honor for me. Let me share my presentation here. Yes. All good from your side? You can see it?
Yes, we can see that. Yeah, that's fine.
Pretty good. So, I feel I'm preaching the already converted today. That's a little bit different than usual. So, yes, I've been working for MSF for quite a while, and my job now is to engage our healthcare workforce into the sustainability journey we started a few years back. And there were some challenges, and I would like to share a bit how we went around these challenges. And so yeah, so I'm very excited to share a bit. I would say the communication tool we developed, and a bit the practicalities of what we've identified as levers to reduce our environmental impact as healthcare workers. I will start with a bit of a background. So I will quickly describe what MSF is and what are our environmental commitments. And then we'll share the way I approached our medical teams, including our medical directors or general directors, into exploring what is sustainable medical practices and how we can be both safe and sustainable at the same time. So just to set the stage, MSF is a really big organization that's around for a bit more than 50 years. We have 5 key offices around Europe in Paris, Barcelona, Brussels, Amsterdam, and Geneva. I'm personally based in Brussels. And recently we opened a 6th one in Western Africa, in Abidjan, in Côte d'Ivoire. All of these offices, they send people in the field, and there are other partner sections that are linked to it. And UK, for example, is right there, is linked to MSF Amsterdam. So it means that people from the UK will be mostly recruited for projects that are organized by MSF Amsterdam. It also means that you have more chances to work with somebody from Germany or from the Netherlands. While in Brussels, I would most likely work with somebody from Italy or Denmark. That was just to set the stage. There is also an international office, and today this is where I'm working. The international office is a little bit like the UN of MSF. So it's a place where we gather, where we discuss, and when we have a common agreements, then we can move forward. So it's really just a place for discussion, and me as an advisor, I bring some content to the discussion, but it's up to the referent to then decide. MSF, it's around 50,000 staff in 75 countries. It's around 10,000 hospital beds. I tried to find something similar in the UK. I found that it's around the size of the Scotland healthcare system or Wales, around 10,000 beds, more or less, but please correct me if I'm wrong. So it's quite a big organization, and 75 countries means a lot of different contexts. Out of the staff, around half is medical, the other half is logistics, supply, administrative. And from the 50% that are medical, a quarter are nurse and midwife. So we speak about 12,000 nurses and midwife total. 75 countries and contexts that are very vulnerable to climate change. So we work a lot on adaptation, but also on mitigation. And due to these contexts, we also advocate for action because in MSF, we use the French word témoignage. When we see things, we feel the need to speak about it. And climate and climate impact are part of it now. And due to what we were witnessing, there was a strong will inside the organization to do something about it. So there were some motions, took a bit of time, but in 2021, a strong global decision were taken to reduce our impact on the environment with objective to reduce by 50% our emissions by 2030 compared to 2019 baseline. So it started the whole movement with a few key people to measure, organize, plan, and make a roadmap. The footprint of MSF looks like this. It's not easy to read, so I made a more schematic one. So it's more or less half goods and services, a third for transport, both for freight and staff, and a sixth for energy and the fugitives. You can see it's quite a bit different from a general hospital. If we look at the hospital level, it's very similar to a hospital in the UK with mostly a scope 3, with 80% being what we buy, and pharmaceutical and medical item being the big chunk of it. But of course, we are international all over the globe, and so transport has a way bigger part in our footprint. From this baseline, we have objectives, and to reach them, we build a roadmap. You can see that medical practices are part of it. It's quite an old one. It was built in 2021. So, for example, review of protocol is not really what we're doing. It's more implementation of them. But you can see that mostly, globally, the idea is to work on our supply chain, from transport, use of goods and services, the way we store them, and the way we deal with the waste. So that was a bit like the big picture. The thing is that when we look at medical practices, we face the same issue that might have been faced a few years back in the UK or other healthcare systems. It was packed with myth, and it's still, there is a lot of resistance. And you might be familiar with Mr. Watts. So former NHS sustainability lead, is now leading the Center for Sustainable Medicine in Singapore. And he shares that there are key myths when we talk about sustainable medicine. First, we don't know what to do. Then, well, okay, let's do it, but it shouldn't impact quality of care, and it might. And third, it's too complex. And again, these are myths. We will see through the presentation that we know what to do. We know that quality of care and sustainable medical practices are two faces of the same coin, and that we are already doing some of it. So yes, it's complex, but we're already doing it. And where to start? And that's where I'm going to bring this safe and sustainable perspective, to identify the role of medicals and see that quality of care is really central to these efforts. And all of it started from a reflection, because as we saw, it's another way to see what's our footprint. We see that procurement has a big role, transport has a big role, energy has a big role, but there is one big actor that is missing from here, is the healthcare worker. And as I mentioned before, it's around half of MSF workforce. So what is the role of medical exactly when we look at this? As I mentioned before, we have a roadmap with some medical practice, but most of the domains are linked to the supply chain. The supplier, transport, storage in the facilities, and end-of-life management. And this is no different from a hotel or a restaurant. However, healthcare facilities are quite a bit different. And in healthcare context, there is a whole set of parameters and factors that influence the consumption of single-use medical items. So what are these factors and what can be done? To explore that, I'm using the work of Mr. Kaya. Mr. Kaya is a Japanese economist in 1993. he built a mathematical equation that linked the resource that we consume by a population to grow the economy and the pollution that was generated from it. And we can use his approach to identify the key factor that link the resource we need to manufacture our medical item, the item we use to provide care to a patient, and the patient we care for. To start with this demonstration, I begin with all of the resources that we need in healthcare for manufacturing, transport, in the facilities, and the end-of-life management. We need raw material, aluminum, steel, plastic, wood. We also need fuel, we need electricity, and all of these activities generate waste. Can be greenhouse gases, other type of gases, antibiotic in the wastewater, radioactive waste, all kind of waste. All of that is, in my perspective, use of resources, raw material and waste that we generate. And then I'm going to Mr. Kaya's work. And Mr. Kaya says, to begin with, that the use of resources equal itself. It's a tautology, a statement that is always true mathematically speaking. And then we multiply and divide by the same factor again and again. So I'm going to multiply and divide by the medical item that we use as healthcare professional. I will multiply and divide by the care we provide to a patient, and I multiply and divide by the patient we care for. By doing so, we identify 4 key parameters that influence directly the resource consumption of healthcare. And these factors, medicals know them really well. We look at the resource we use per item, the number of items we need per act of care, the number of acts of care that we give to a patient, and the patient we care for. If we look a bit more deeply, first parameter, impact per item. How can we mitigate, how can we reduce the amount of impact or the resource intensity linked to each of the medical items we use? We can work on manufacturing, transport, storage, and disposal. I can make the link to an example to illustrate what we've done in MSF. As I mentioned before, a quarter of our footprint comes from the goods we purchase. We looked at everything that the medical staff is purchasing or using, and we realized that 2/3 of the goods that were used by medical professionals were single use. So we wanted to know a bit more. So we did some analysis and we looked at the quantities. What do we use? We realized that gloves were the main player, but personal protective equipment is the main big family in terms of quantity. The second one being devices for injection, syringes, needle, catheters, and infusion sets. We did a second analysis by weight. So we multiply quantities by the weight of each item. And here, the gloves are even further the first in the list. But again, personal protective equipment and devices for injection. We wanted to know a bit more because all of these items are made of very different raw material. And with an environmental perspective, we know that plastic, latex, steel, aluminum, paper, all have very different impact on the environment. So we looked at what we most consume, and we applied a simplified LCA approach. So we looked at the material of each of the item, had applied impact factor to it to have a measured impact per item on climate change, human health, and plastic pollution. So CO2 emissions, human health is the air pollution linked to the waste management, and plastic pollution is when you do landfilling of the plastic, which we don't do. Basically, we mostly incinerate our medical waste. When we have that, we multiply by procurement quantities, and so we have the total impact per item for MSF settings. And here are the results. You can see that the gloves and the personal protective equipment is still really high in the list, and devices for injection are still there as well. There's a big difference is that items containing PVC are way higher due to the impact at the waste management stage. So that's one of the conclusions of one of our projects, the Rethinking single-use project. which identified the disproportionate impact of PVC when we look at items themselves. We also identified that the weight of the item was directly correlated to the impact on the environment. So a priority for us will be to look for lighter alternative or less packaging also. And we've also identified that two main priorities for us to work on would be the personal protective equipment and the devices for injection. When we talk about impact per item, there are other opportunities. This was just an example, but implementing reusable directly reduced the resource that we use per medical item. In MSF, we use a lot of reusable surgical caps and surgical gown, with the caveat that we need a good capacity for laundry and sterilization, and that's not always available. We also realized throughout the project that we lost quite a few reusable. Some were available just a few years ago, and these ones are really difficult to procure on the market at the moment. This was looking at the items themselves, but we can also work on the way we transport our items. So MSF is an emergency organization, so around between 30 and 50% of our projects are in emergency settings. So we transport a lot of our equipment by air, but trying to reduce the amount of tonnage that we send through air is a big part of our roadmap for 2030 as well. So as I said, on the impact per item, we can work on multiple aspects, but that's just one parameter. We can also work on how efficient we are or how responsible we are at using our resources. So to be efficient in our use of resources, we can use 5 key levers. We can rationalize the use, so to tackle overuse or misuse of item. We need efficient forecasting to avoid wastage, expiry date shortages. We need efficient stock management, so short expiry date should go out first. We need efficient maintenance, typically for the biomedical equipment. If we take good care of it, we can increase the lifespan of it and therefore use a bit less overall. We can also choose medical techniques that use a bit less equipment. A good example is the local regional anesthesia, when clinically appropriate. We try to implement it in more and more projects at the moment to replace general anesthesia in the case where we can do the switch. Some example in MSF that I can share to illustrate this parameter. The work on glove. We had a direct contact with the Gosh Hospital in London with Nicola, and she shared with us a bit the approach they took to reduce the consumption of single-use examination glove. And we mimicked the campaign with the campaign manager, with posters, with key messages. And we were super happy to realize that we actually reached very similar results with around a 40% reduction in glove consumption per consultation, with all of the co-benefits attached to it: less transport, less stock, less waste, a better hand hygiene, adherence, probably, but we haven't measured the reduction in healthcare-associated infection. However, that's a behavior change campaign, so it required quite some efforts. That's just one example, but switching from IV to pearl, you can give the same treatment, for example, 1 gram of paracetamol with less equipment. So you don't change anything to the care provided to the patient. You just reduce the amount of medical equipment that is needed. So therefore, you're more efficient at using the resources that we are in MSF when this is done. It's already in the guidelines, but it requires implementation. And I mentioned it before, but this is the picture from a colleague that clearly described the amount of item you need to do a general anesthesia and the one you need to do a eco-guided local regional anesthesia. Beside, again, all of the co-benefits of better pain management, shorter length of stay, less nursing time, better patient satisfaction, and overall less carbon emission due to the manufacturing of all of these items. And I'm not even speaking about the anesthesia gases here. You'll be I know. Not happy, but I'm just sharing that MSF has phased out death run a few years ago, so that's already something that has been done. A third parameter. So now that we've worked on the item themselves, we can work on the act of care. So what do I mean? Looking at the amount of care that each patient requires, is how can we bring effectiveness? How can we be more effective? And through that, how can we use the least number of treatments or reduce the risk of side effect generated, reduce the risk of patient safety incidents, or increase the adherence of treatments? So how can we be effective? And this is described by WHO already. So which described that quality healthcare through the dimension, all of them, is effective. If we're safe, means providing the right drug at the right dose at the right time to the right patient. We don't create an extra need to further treat or a second, third treatment. If we are timely, we provide early diagnostic and treatment, and therefore we don't need to treat for something else later, or the disease is not has not progressed, and so the situation of the patient is less severe, and therefore reduce the amount of resources needed to treat him. Evidence-based, of course, because we need to implement best practices through training. Equitable and patient-centered means appropriate, adapted, and acceptable by our patient. A non-accepted treatment will not be taken or will be taken in a non-effective way, and therefore will probably need to be repeated. In MSF, we have tools to implement that. So safe care is measured through some indicators. We can report patient safety incidents. We audit rational prescription. We measure a score. We assess patient experience. I'm not saying that we do that everywhere all the time, but these are the tools that exist and that we promote the implementation of. We organize morbidity and mortality review, promote IPC approach to the implementation of hand hygiene and the 3 pillars of IPC, and monitoring is possible. So that's just an example. And timely to connect with our operations. One example in Malawi, we realized there's a big problem with the cervical cancer due to the former HIV outbreak some dozen years ago. And so it's very important to have a timely detection so that the treatment can be done effectively. Early detection means early treatment, means less resource spent and better quality of care. Beside timely detection, you need also timely management. Again, an example of what we do for the past 10 years is a course for nurses, typically for hospital settings where we lack doctors. So there are many countries where we don't have enough doctors. So we need the nurse to be able to manage the first 5 minutes of a critical situation. So first detecting the situation and then taking care of it. I think about shock, respiratory distress, convulsion, loss of consciousness. And then during these first 5 to 10 minutes, which is the time for maybe the on-call doctor to arrive, to take the first life-saving actions. And this course has been given, as you see here, in hospital settings, mostly for nurse and midwife, and mostly really in healthcare systems that really struggle with the number of healthcare worker and qualified healthcare worker. And finally, the last parameter that we can work on is to target disease incidence. How can we minimize the need of healthcare services? And this can be done through 3 main mitigation action or pillars: prevention, health promotion, and disease management, or patient education. A good example for that one is a diabetic patient. If the patient knows well his disease, if it's well managed, he won't need the hospital. If it's badly managed, it can lead to amputation, infection, neuropathy, and use a lot of resources in the healthcare system. The example here are plenty. I just picked 2 in MSF. Our health promotion team have tool to promote breastfeeding. And this is one of the single most effective preventative measure for child health. another example, and that links to a concept from the UK to make every contact count, which we should take every opportunity of exchange or interaction with healthcare services to bring health promotion, health education, key messages. And here we have built a tool to assess the vaccination status of a kid to check if there is need for a catch-up on essential immunization according to the WHO program. So we see that the use of resources in healthcare systems is linked to 4 key parameters. One of the key advantage of this message is that it has a multiplicative effect. So there is sometimes a lot of discouragement when we look at our objective. I mentioned the 50% reduction by 2030. But we see here that decarbonization efforts can be shared, and a bit of a thought-provoking exercise would be to say that if we have items that are 15% less carbon intensive, if we are 15% more responsible in the way we use our items, if we provide 15% better care, and if we are a bit better at promotion, then we might be able to reach a healthcare system that use 50% less resources and produce 50% less waste. And we see also that it's not only a matter of supply chain or manufacturing, but that everybody in the healthcare system has a role to play. To summarize, we've seen that healthcare resource consumption depends on 4 key parameters: resource per item, item per care per patient, and the need of healthcare services. We've identified key levers for mitigation for each parameter. We need a sustainable supply chain, so low carbon procurement, efficient transport, efficient facilities, reduce fugitive at the user level, and proper waste management. We need resource stewardship, so rational use, efficient medical techniques, efficient stock management, efficient forecasting, and efficient maintenance. We need quality of care, care that is safe, provide timely diagnosis and treatment, implement best practices, ensure that patient gets what they need, being equitable, and provide care that is patient-centered, so appropriate, acceptable, and adapted to the patient situation. And we can reduce the number of patients that needs us through preventing the need of healthcare services, through health promotion, disease prevention, and better disease management. Overall, a sustainable healthcare system is a sustainable supply chain, resource stewardship, quality of care, and preventing the need of healthcare services. So we see now that quality of care is sustainability, and the same way we will see that there will be no sustainable healthcare without quality of care. And that hope it killed the myth that we've identified earlier, and that, well, we actually know what to do. We've seen that quality of care has a central role to play. And, well, of course, medical care is complex, but we are already doing it. And a very last consideration is that when we speak about the role of medicals, when we ask the public who they generally trust to tell the truth, politicians score the lowest and nurse score the highest. Doctor as well, but nurse a bit better. And so what we do and what we say matters. And I'll leave you with this consideration, and I look forward to your feedback and questions. Thank you.